So we can start, Kalpana?
Yes, ma'am, please.
Okay. Good afternoon, good morning, good evening, and I know some of you are connected from the US, especially one of our panelists who has 3 a.m. in the US. I would like to first of all welcome you to our WHO IIPH webinar series on promoting health throughout the life course during COVID-19 pandemic. Today's webinar, which is our 9th webinar out of the 11, which we have in collaboration with Indian Institute of Public Health, is on situation of abortion and availability of medical abortion in the region. I'm very grateful for many people who have connected to this webinar, and I would like to first of all extend my warm welcome to the panelists. It's a very, very interesting panel who has extremely good experience. I'd like to welcome panelist Dr. Antonella from our WHO Geneva. She's a colleague and she works as a medical officer in preventing unsafe abortion. I'd also like to welcome Ms. Sofia Sedinsky, who is the Senior Global Policy Manager from Guttmacher Institute, New York. Thanks, special thanks to you, Sophia, because I know in the US it's 3 a.m. and that shows your commitment to a cause where you would like to share your experience with us. I'd also like to welcome and thank Mr. Terence, who is working with us in Health System Department in WHO Regional Office for Southeast Asia as a technical officer looking after essential drugs and other medicines. And most importantly, Dr. Nini Luen, who is the Deputy Director, Maternal and Reproductive Health, Department of Public Health from Ministry of Health and Sports in Myanmar. So I think this is a panel which is extremely interesting, and we are grateful to all of you for connecting. And I'll also like to welcome Professor Dilip Mavlankar, who is the director of Indian Institute of Public Health in This webinar will be moderated by Dr. Meera Upadhyay, who works with us as a technical officer for sexual reproductive health. She is a very dedicated colleague, making sure that women go through, safe abortion and post-abortion care services are also, given. Now, you must be wondering why we are talking of, situation of abortion and availability of medical abortion drugs. Abortion is one of the important and leading cause of maternal mortality in many countries. In some countries, the contribution of unsafe abortion is 8 to 16% of the maternal mortality. So it's a very important cause of maternal deaths. At times we all wonder, when we talk of abortion, that means there is a woman who has gone through a pregnancy which is not wanted. So that means she either did not have access to contraception or she did not have access to, contraceptive services. And when she becomes pregnant and it's an unwanted pregnancy, she wants to undergo abortion services. And there are countries where the legal restrictions vary in our region from one country to the other. Some countries are very restricted, some countries are not so restricted, they are relatively liberal. But most importantly, I think the issue is that once a woman goes through abortion, whether medical abortion or otherwise, I think post-abortion care is extremely important to prevent complications of abortion. So hence, I think comprehensive abortion care is extremely important for countries to consider, irrespective of the legal situation. As WHO, we do not really, tell any member state of Southeast Asia region, whether you should legalize or you should not legalize. But we make sure and we promote comprehensive abortion care services with a particular focus on post-abortion care, because the countries which have very good emergency medical obstetric care services, where they have blood transfusion, they have other drugs which are required to save the life of a woman, they are able to save life of women from complications of unsafe abortion and clandestine abortion. So it's a very, very sensitive, but at the same time, very important area to address. I remember way back, I'm talking of 1976, the first autopsy during the training which was conducted was a young woman who was just 18 years old. When she was opened up, the cadaver was opened. There was a 4-month pregnant uterus with a stick going through and through. And that is something which changed my life, and I picked up public health as an important, discipline to follow. Because no matter how much we do in the, hospital settings, but unless until women are empowered, there is awareness, there is access to contraceptives, the choice is given to a woman to be pregnant when she wants to be, and if abortion services are available, whether medical abortion or other services, those are accessible to her without stigmatization. So I think those are the areas which are extremely important for us to address. And this becomes more important because there are out of, in countries where, like India, where abortion is legal, uh, the services are much more, accessible to those who are married. But then we know that out of wedlock, pregnancies are also common, and these young girls don't know where to go. There's so much of stigma, and they land up with private sector. And at times, the private sector also is not able to provide them the kind of services they require, and the kind of money they have to pay, and the risk which they have to take. And a lot of clandestine abortions hence happen because of lack of access to services. With these words, I know it's a very important area we are addressing today, and we have wonderful panel members who are passionate about it. But then, as I said, the reality is that we do not have enough data and information when we talk of situation of abortion. How many unsafe abortions are being conducted. And I think maternal death surveillance and response, MDSR, has really helped countries to really know why did this mother die. And that's what is telling us that a lot of women die because of unsafe abortion and complications arising out of unsafe abortion. So with these, I would like to hand it over to our collaborator, Professor Dilip Mavlankar, to give a very short view of what is Indian Institute of Public Health. What do they do? They do wonderful work. So over to you, Professor Dilip Mavlankar, and then I'll request Dr. Meera Upadhyay to take us through, this webinar and moderate this webinar. Over to you, Professor Dilip.
Yeah, thank you very much, Dr. Neena. Your moving story of the woman having abortion, death, also stirred my memory. As a first-year surgical resident, I have seen such cases, even coming with burns. And under treatment of burns, we realized that woman is pregnant and aborting on the surgical table, which we had not thought of when she first came as a burns case. So such sad events, and this is almost 40 years ago now, I'm sure things have improved. But as everybody knows, abortion is still highly sensitive topic in many cultures. There are very few places in the world where it may be less sensitive. And hence, and especially in these COVID times, this becomes even more difficult, where even regular health services became a problem to access. The Indian Institute of Public Health, Gandhinagar, is part of the government of Gujarat and the Public Health Foundation's joint initiative. It is the first public health university of India, and we offer Master of Public Health and Master of Hospital Administration courses, as well as short certificate courses. And we have a multidisciplinary faculty. We have a strong faculty in maternal and child health, and we have been working on many areas of this topic. And hence, we would be delighted to hear this esteemed panel speak on issues related to abortion and its data, as well as its public health implications, and learn from Myanmar's experience in this webinar. Thank you very much for collaborating with us, and we are delighted absolutely to co-host this webinar series with WHO Regional Office. Thank you, Dr. Neena.
Thank you very much, Professor Dilip Mavlankar. I think we are privileged to have your team work on it so seamlessly. I would now hand over to Dr. Meera to moderate this session, please. Go ahead, Dr. Meera.
Thank you, Dr. Neena. Generally, when, as you have already mentioned, as Dr. Dilip have highlighted, like working in abortion and finding out, trying to save women from complication of abortion is a very difficult job, because whoever speaks about abortion, we always think that we talk about induced abortion, but it is not that. There are some other natural abortions also, like spontaneous abortion, complication of spontaneous abortion, the septic abortions. There are so many things, but even then, socially, culturally, and maybe religiously, we really link this abortion with the induced abortion, and then we try to somehow, dim it, and we bring it out. So due to that, we really have a very limited information about the evidences, about the data, about the cases. So whatever evidence we have is like some countries have a national level MDSR data, and some estimates we have. So today in this webinar, we want to let you all know, all the participants know that what are the global evidences we have, where we can go and search. So what are the global institutes doing on that, especially to gather the information, so that when we are planning our programs, or when we are thinking of supporting prevention of unsafe abortion, death of women due to unsafe abortion, then we will know where to look at and how to think and how to analyze and how to make a program, successful program. So saying this, today we have a very esteemed panelist, and with a very important information, the latest information for us. So now I think we will start with the first presentation from Antonella. She has already been introduced by Dr. Neena. She's a medical officer. She's working in WHO headquarters, and she is the main person who worked on the global abortion database. And today she'll be taking us through this database. She will tell us what are the things there and how to work on that database to find out the information that we need to program, to do the research, and to use that data. So thank you so much. Please, participants, stay tuned and keep your questions for each of the panelists after their presentation, and put it in the chat box. Then we will answer your questions at the end of the session, when all 4 presentations would be over. So for the panelists, you will have 12 minutes to present. At 11 minutes, I'll just warn you that you have 1 more minute left. So thank you all of you. Dear Dr. Antonella, kindly please start your presentation. Thank you. The floor is yours. Thanks.
Thank you so much, Dr. Meera. Thank you for allowing me to participate today. I feel very privileged and excited to be here with you all. So as many of you may know, WHO is a norms and standards setting agency, and we have several guidelines that speak to the provision of comprehensive abortion services. Next slide, please. This includes induced abortion, management of abortion complications, management of intrauterine fetal demise, all the various types of abortion that Dr. Meera mentioned, as well as contraception provision by various health workers. Next slide, please. So why do we do the work that we do? We'll hear more a little bit later about abortion incidents, but in brief, there were approximately 121 million unintended pregnancies between 2015 and 2019, with 61% of those ending in abortion, or 73.3 million. Next slide, please. We also know that there are approximately 25 million unsafe abortions each year, and this translates not only into personal loss, but there are great impacts on families and communities at large. And previous estimates show that an estimated 7 million women have been treated in the hospital for unsafe abortion. And this, of course, translates into billions in financial costs. Next slide, please. There are also human rights issues. Specifically, discrimination, stigma, and lack of respect for the confidentiality of patients may deter women, girls, and pregnant individuals from seeking advice and treatment, which thereby adversely affects their health and well-being. And this is magnified by the inequality and iniquity in access to safe legal abortion, but also to information and other needed resources. Next slide, please. WHO recognizes that health is a human right. Here's the WHO definition of health, and this definition also applies to sexual and reproductive health. And so as you can see, a state of complete physical, mental, and social well-being. And while all member states accept this definition, many countries' laws do not refer either to the WHO definition or reference explicitly all the component parts of health. Next slide, please. The right to health includes both freedoms and entitlements. So this includes the right of all couples and individuals to access information, have the means to decide freely and responsibly the number, spacing, and timing of their children, the right to consensual partnership, and the right to benefit from scientific progress equally. So how do we deliver on this? Next slide, please. In addition to health system infrastructure issues, WHO says that laws and policies should ensure that all those that are legally eligible have access to timely and safe abortion care, facilitate the provision of high-quality contraceptive information and services, and meet all women's SRHR needs. All of these things are particularly important now during the pandemic, and at the start of the webinar series, individuals received information about how to maintain essential services. But to be able to do these things, as well as to appreciate how laws and policies impact access generally, we must first be able to assess the breadth at which they exist. Next slide, please. Several databases exist which provide information related to abortion laws. The UN specifically has gathered information on legal grounds for abortion and some related policies since 1987. Next slide, please. WHO provides a tool called the Global Abortion Policies Database. The vision for the database was to update laws, provide new details related to the legal categories for abortion, such as gestational age limits and other access requirements, and to expand beyond laws to broader health policies. The project began in January 2015, at which point a number of data collection teams located in different regions of the world were commissioned to retrieve official policy documents and extract selected data onto a policy questionnaire that was based on our guidance. The questionnaires were cross-checked a number of times against source documents by both public health and legal experts, as well as sent to countries for review. Launched in 2017 with an intended audience of policymakers and their advisors, sexual and reproductive health and rights, non-governmental organizations and other groups, human rights bodies, and researchers. Next slide, please. So let's have a closer look. Here's the landing page. It includes country abortion laws and policies for 198 UN member states, linked directly to downloadable source documents, and this is juxtaposed to relevant WHO guidance. All the information is what we've been able to find, and we realize that there's still a great deal of information out there. We may not have been able to verify or find old documents, and sometimes we've faced translation issues. We initially received direct inputs from 85 countries, and we continue to receive them today. And we now have approximately 2,000 sources. Next slide, please. You can choose from the filters on the world view, and the countries will illuminate. A tally is provided as well. Next slide, please. And you can see here that as you toggle across the various filters, there are sub-filters available. Next slide, please. And even within filters and sub-filters, there are further pieces of information. So here, under specific clinical requirements, under methods allowed, we have information about medical access, surgical access, so the availability of MBA, for example, or mifepristone and misoprostol, and what is actually dictated in the policies about those methods. Next slide, please. You also have the option of doing a country or regional comparison directly from the home page. Please note that the regions are UN and not WHO regions. Next slide, please. When you click on country comparison, this is what you see. Next slide, please. And you can choose which filters you'd like to compare. You can select all or pick individual ones. You can also use the advanced filters to the right to look at human rights treaties which have been signed, what concluding observations exist by various human rights treaty bodies, and what penalties exist for women providers and those who assist in the process. Next slide, please. So here we have information about several of the legal grounds for the countries in the SEAR region. Additional grounds exist if you scroll to the right. Next slide, please. And this is true for all of the tables. You can scroll to reveal the additional filters. Next slide, please. You can see that there are checks and X's which correspond to a yes or a no response. And when you click on these, a pop-up appears. But there are also I's, which means that the answer is not as straightforward as a yes or a no, or there may be additional information. You can see here that by the many X's that access is legally restricted in several countries in the region, but it is important to note that every country in the region has at least one legal ground available. Please note that Bangladesh offers menstrual regulation as well, and Nepal has on request, but no other countries do. This is particularly important now, as we know that unintended pregnancies are rising, and some may be choosing to terminate, and some may be doing so unsafely. Next slide, please. We have information related to additional requirements, such as how many authorizations are required, parental spousal consent requirements, as well as whether police reports are required in cases of rape, among other things. Next slide, please. As an example, if we look more closely at Thailand here and the need for additional authorizations, we see, next slide, please, that 2 authorizations are required, and where the cadre of providers required is specified, the information is also provided. As mentioned earlier, you can see how each response is juxtaposed to the information or recommendations that exist within the guidelines. It is this kind of information that can be helpful in considering the impacts to access, especially now during the pandemic. In addition to issues with geography, where access to a single provider may be extremely difficult, it can be helpful to consider if and how things like telemedicine can be utilized. That's something that came up in how to maintain essential services during this time. Next slide, please. Here you can see the service delivery aspects that exist, including the existence of guidelines, what methods are permitted, where and by whom abortion care can be provided, whether contraception is included in post-abortion care, and whether mifepristone and misoprostol exist on an essential medicine list or some other official list. Next slide, please. Similarly, for Maldives, if we click on the check for mifepristone and misoprostol, the following pop-up appears. Next slide, please. We can see that there is country recognized approval for mifepristone and misoprostol, but we can also see whether a pharmacy can sell or distribute the medication. The same information is available for misoprostol only. Again, consideration of ways in which requirements for prescription for abortion medications can be relaxed, especially where the rules exist within regulatory or policy documents, as opposed to penal codes, and the need for forecasting for abortion commodities and supplies are important to consider during such times. Next slide, please. Here I'm showing the results of the conscientious objection filter, and you can see we're missing a great deal of data in many countries about what is or is not specified in the law. Next slide, please. And finally, here a comparison of the existence of specific concluding observations made by various human rights treaty bodies in the region. Again, you can click on the check and they appear in a pop-up. Next slide, please. Finally, the database allows you to go directly to a country's profile, either from the home page or within country comparison. So here it is from the home page. Next slide, please. So I've just chosen an example. So I've picked Myanmar, and when you land on the country page, you get a snapshot of what we have available, including what source information is available, the concluding observations and penalties. If you scroll down, each of the tables are available: legal grounds, authorization requirements, service delivery aspects, etc. Next slide, please. In addition to the tables mentioned, we also have a table with penalties for those involved in the abortion process, including the woman herself. Here I've clicked on the penalties for a woman and this pop-up comes up. Next slide, please. Please note that if we click on penalties deconstructed, you can see the following results from Myanmar, that legal grounds are specified and there are penalties for other abortions. This is important because in the database, laws can be grouped into one of the 5 following categories: complete prohibition, unlawful abortion is permitted but prohibited, but no information exists as to how unlawful abortion is defined. Abortion is permitted on 1 or more grounds. Abortion is permitted on request with no justification as to reason, and where abortion is regulated only as a health intervention in the health system. Next slide, please. We also have specific indicator information available, both linked to the SDGs as well as 18 additional reproductive health indicators that go beyond those specifically related to abortion, more about participation in the community, paid paternity leave, secondary school completion. Next slide, please. Finally, there are additional resources available to you on the database. Next slide, please. We continue to see that laws impact safety because often legal and regulatory requirements act as barriers which contribute to the chilling effect, and this can lead individuals to seek unsafe abortions. We hope that the database can be a resource for you, both in terms of your queries to countries about their existing legal and policy environment, but also about what they can be doing potentially differently. Next slide, please. Finally, by appreciating the impact of laws and policies on practice, we can better work together to reach the Sustainable Development Goals. When we speak of sexual reproductive health and rights, we often focus on SDG 3, reducing maternal mortality and ensuring universal access to sexual and reproductive health care services, and 5, end all forms of discrimination against all women and girls, and ensuring universal access to SRH and reproductive rights everywhere. Next slide, please. But by doing so, we're able to also help countries appreciate the impacts of other SDGs, because we know that women and girls' lack of autonomy over their health can limit their outcomes on education, employment, and political participation, among other things. Last slide, please. Thank you so much, and I, again, appreciate the opportunity to participate.
Thank you, Antonella. Thank you so much. This is very informative, and this is very helpful for all of us. And thank you for keeping up with the time. Thank you so much. So at the beginning, Dr. Nina also highlighted about not having information and database. So this is one that we have, but still we need to understand
I think we lost Mira's voice. Okay, so may I request Sophia to kindly go ahead and make the presentation? Thank you.
Sure, happy to. Good afternoon, everyone. Thank you so much to the team at the WHO Regional Office for inviting me to participate in this discussion. It's really an honor to be here. My name is Sophia Sadinsky, and I'm the Senior Global Policy Manager at the Guttmacher Institute. Today, I'm going to present new regional estimates of unintended pregnancy and abortion from 1990 to 2019, and we'll talk through some of the key policy implications. These are findings from an established study that we've undertaken periodically in partnership with the WHO's Human Reproduction Program. For the first time this year, the study jointly estimated both unintended pregnancy and abortion. The estimates are presented by country income group, by the legal status of abortion, and by geography, using the Sustainable Development Goal regions. For this presentation, I'll be highlighting estimates for Central and South Asia, which covers 14 countries. From the WHO Southeast Asia region, these include Bangladesh, Bhutan, India, Maldives, Nepal, and Sri Lanka. These new estimates were published in July in Lancet Global Health. I've included a link at the end of my presentation. So while I'll be focusing on the regional outcomes of this study, I want to first highlight 3 themes from the global findings, which you'll find here on this slide. The first is that unintended pregnancy and abortion are reproductive health experiences shared by tens of millions of people around the world. Despite the universality of these experiences, we know that what differs are the obstacles that people face, legal, social, economic, or otherwise, in exercising their reproductive autonomy. Second, unintended pregnancy and abortion occur both where abortion is broadly legal and where abortion is restricted. In fact, the percentage of unintended pregnancies ending in abortion has actually increased over the past 30 years in countries where abortion is legally restricted. And third, unintended pregnancy and abortion rates are higher in low-income countries than in high-income countries. Those in the poorest countries were nearly 3 times as likely to face unintended pregnancies as those in the wealthiest countries, suggesting major and persistent inequities in access to sexual and reproductive health care. And while the focus of today's discussion is on abortion, I'll be incorporating the estimates of unintended pregnancy to underscore the importance of taking a holistic approach to sexual and reproductive health and rights. This is one that encompasses the right of all people to make decisions about their bodies, free of stigma, discrimination, and coercion, and to have access to essential health interventions to support that right. Next slide, please. So I'd like to start with a global snapshot. These bar graphs show the unintended pregnancy rate on the left and the abortion rate on the right by region. You can see the average annual rates for the regions in Asia in the middle blue bars that I've indicated with red arrows. Since 1990, as access to contraception has increased, the rate of unintended pregnancy worldwide has fallen. As Dr. Antonella noted, from 2015 to 2019, there were 121 million unintended pregnancies annually. This corresponds to a global rate of 64 pregnancies per 1,000 women. You can see that both regions in Asia hover around that global rate. So what does this mean in terms of abortion? Overall, 61% of unintended pregnancies ended in abortion, or just over 73 million abortions on average each year. That means for every 1,000 women, there are 39 abortions. The regions in Asia are relatively close to the global rate, as you can see on the right. Next slide, please. Now I want to take a closer look at a region that we're interested in for today's discussion. As we all know, there's immense variation among countries in terms of the political, cultural, legal, and socioeconomic realities and health systems, so this is only meant to provide a regional overview. In Central and South Asia, the unintended pregnancy rate, which is that top line in blue, declined by 28% over the past 30 years. Meanwhile, the researchers found that the region's abortion rate has increased slightly, as you can see from that bottom green line. There are meaningful differences across regions. However, with this region as well as other, a shared theme emerges. Unintended pregnancy rates have been declining, while the percentage of those that end in abortion has been increasing. This speaks to the importance of providing the full spectrum of sexual and reproductive health interventions, which includes contraception so that people can decide whether and when to become pregnant, and abortion care to safely end a pregnancy. Next slide, please. So how do we make sense of these data from a policy and advocacy perspective? I'm going to start by looking at some of the priorities that we've identified for governments, then shift to policy actions for other stakeholders, and close by talking about these findings in the context of COVID-19. For countries, there are at least 2 main tracks of action. First, on the fiscal policy side, we see how sexual and reproductive health must be prioritized in domestic budgets to address unmet need for contraception and safe abortion care. We hope that there will be greater awareness at all levels of government about the cost effectiveness of sexual and reproductive health and how it's an investment in the future. On the legal and policy side, this research demonstrates the need to adopt the WHO standards for safe abortion care and promote task shifting to more types of healthcare providers in order to expand access. Now, making abortion legal is critical but not sufficient. In a separate study we undertook with partners in South Asia, for example, researchers found that in India and Nepal, less than 40% of public sector facilities that are permitted to provide abortion services actually do so. This underscores the huge gap between the law and implementation when it comes to access to safe abortion care, especially for marginalized groups. Next slide, please. Next, I want to highlight a few policy actions for other stakeholders, including regional bodies, provider associations, and advocates. Regional bodies and instruments, for example, the Maputo Protocol for Africa and the recommendations established through the Asian and Pacific Population Conference, are important vehicles to unify country governments around a common agenda. Provider associations have an important role to play when it comes to designing and implementing clinical guidelines related to sexual and reproductive health and rights, including safe abortion. For advocates, we hope this new evidence can help support the case they are making to policymakers about the importance of looking at abortion laws. We have seen a greater push to take a comprehensive approach to these issues to ensure that the arguments we are making are both evidence-based and grounded in human rights. Next slide, please. Before closing, I want to just touch on what this means in the context of the COVID-19 pandemic, since the data I just presented were collected before the pandemic. As we all know, abortion is a time-sensitive, essential health service, and every year tens of millions of abortions happen safely. But during the pandemic, we are concerned about many of those becoming unsafe. We know from prior work that inhibiting access to safe abortion doesn't make it go away, but it does make it less safe. As part of a separate research project, our institute decided to look at a scenario in which 10% of abortions that are currently performed safely would become unsafe. That is, abortions that do not use a WHO recommended method appropriate to the pregnancy duration, or are not done by a trained provider, or both. They found that if just 10% of safe abortions are compromised, that is, made less safe due to lack of access to a provider or supply chain disruptions, we would see 3 million more unsafe abortions and 1,000 more maternal deaths each year. Next slide, please. So we can see that this evidence has relevance in the short term during the pandemic, as well as in the long term as countries repair and rebuild their health systems. First, the research demonstrates that tremendous need remains unmet when it comes to sexual and reproductive health. As such, sexual and reproductive health supplies should be included and prioritized in lists of essential COVID-19 medicines, and this care, including safe abortion, should be deemed essential. We also recommend embracing innovative and inclusive approaches for service delivery, many of which are identified in the WHO's operational guidance in the context of COVID-19. This will facilitate greater responsiveness to emerging needs, such as telehealth options for self-managed abortion. Over the longer term, this research speaks to the need to adopt the recommendations of the Guttmacher-Lancet Commission on Sexual and Reproductive Health and Rights, and include them in supported packages of interventions. This is also true for those focused on universal health coverage, as sexual and reproductive health broadly, and safe abortion specifically, should not get lost in efforts to achieve that goal. Overall, we need to consider the long-term policy implications of COVID-19. This pandemic has prompted us to take a hard look at our policies and ask which are serving us and the communities we care about, and which are causing harm. We have a responsibility to take what all of us have known for a long time about inequities in access to quality healthcare, which are on stark display during this pandemic, and use this to assert what truly good SRHR policy looks like as we work towards building back better. Next slide, please. Finally, I want to close by providing a preview of what's to come. Unlike previous iterations of this work, this time the estimates underwent the country consultation process at the WHO, which means that we will be publishing country estimates for the first time. We anticipate publishing the estimates later this year or early next year, along with a public use data set and tailored resources for key stakeholders such as those in the audience today to interpret and utilize these findings in policy and programmatic discussions. So keep an eye out for those. Next slide, please. In closing, I just want to leave you with links to the research study and a few other relevant resources. I look forward to further discussion. Thank you so much.
What he highlighted was the more we have more restrictions in our legal provision for abortion, cases of unsafe abortion arise in a country or in the region. Similarly, if there are more acceptance and availability of the family planning services in the country or the region, the number of unintended pregnancy and number of complications due to unsafe abortion itself, it is reduced. And the third point is the legal provision of the abortion is actually it is there for the limited indications in all the countries, at least to save the women's life. That one indication is there for all the country. That was highlighted by Antonila's presentation. And there are some countries who are as liberal as, if women thinks that she doesn't that is her unintended pregnancy and wants to be aborted, then she can opt for that. So without any questions, she is entitled to get that abortion services, thinking that it's her right. So there are countries with a various legal status. So especially to focus on reduction of death due to unsafe abortion, one is in spite of having a legal the variation in legal provisions, if we strengthen the family planning programs in the country, if we strengthen the quality of services, post-abortion services or emergency obstetric care services provided in the country, and if we ensure that there is a viability of some other alternative mechanism to reduce the unintended pregnancy, definitely the maternal mortality is going to go down. As Dr. Nina highlighted, that there are almost 16 to 18% of maternal deaths due to complications of unsafe abortion. So these are all preventable causes, and the information which we can gather from the global abortion database and the information we can gather from Guttmach's estimation are very useful for us for the programmatic interventions. Now I request Terence to make a presentation on behalf of regional office. We had done a assessment to assess the medical abortion medicine in WHO Southeast Asia region, drug and medicine unit and MCA unit. So basically, what would be, we have found that in countries where the abortion is liberally legalized, the women, their first choice is always a medical abortion. So the accessibility of medical abortion and quality of the abortion drugs really mortality due to the abortion. So Terence, I request you to go ahead with your presentations. So thank you so much. I again remind everyone, all the participants, to write your questions in the chat box so that we will have a discussion at the end of presentation. Thank you, Terence. 11 minutes for you. Fine, 12 total minutes. I'll give you a reminder in 11 minutes. Thank you.
Thank you very much for giving me the opportunity to share the survey that was conducted by WHO on the access to medical abortion medicine in the WHO Southeast Asia region. So I'd like to acknowledge the WHO staff, the country office staff, the Ministry of Health staff, and all the country participants who actually worked hard so that this report can be finalized. Thank you very much. Next slide. So first of all, let me define the access to medicine framework to understand the broader picture of what it means to have access to medicine. So there are different blocks that actually support access to medicine in every environment. The first block will be the rational drug use, where rational medicine use is actually supported. Then we have affordable prices, then reliable health systems, and sustainable financing. So these blocks work together to actually support access. So when we talk of access to medicine now, it will be based on these 4 blocks that will support access to medicine. Next slide. So there are 4 A's to access to medicines that we can actually recap on. First of all, when you talk of access, we are talking of medicine being available. They have to be available at the point of care. They have to be available so that the clients and the patient can be able to access them. Then they should be accessible. Once they are available in the facility, they have to be accessible to those that are in need of them. Then after they have been accessible, they have to be acceptable. In terms of acceptability, we're talking about acceptability by the health care system, which include the health providers and the legislation and the policies that are in place, and also being acceptable by the end user, who is the client himself, who is actually going to use the medicine. Then above all, the medicine should be affordable. Where the medicine is going to be charged, it should be affordable to the client. So when we talk of all these 4 A's, they support each other to promote access to essential medicine. Next slide. So there are 5 pillars of availability of a medical product in the health system. The first pillar is on registration and quality assurance of medical products, where the medical products are supposed to be registered in a particular jurisdiction, in a particular state, in a particular country. And when they are registered, they should be marketed in that particular country. Then there should be policies and financing systems that support access to the medical product. Then the third pillar will be on procurement and distribution, meaning that once the medicine is available in the country, the procurement system, the distribution system, the storage system should be able to support access to medicine, to a medical product, to ensure that the medical product actually reaches the last mile where it's supposed to reach. Then the fourth pillar will be based on provider knowledge, where the provider who is giving care to the clients should be able to have enough information about the medical products and enough information to take the right decisions at the right time. Then the last will be the end user knowledge, where the user, the clients themselves, should be able to have knowledge on the availability of the service and how the service can be accessed in the particular facilities. But this presentation will focus on the 3 pillars, the first 3 pillars of availability of medical products. These 3 pillars will be registration and quality assurance, policy and financing, and procurement and distribution, where we'll be focusing mainly on medical abortion medicines. Next slide. So the methods that were used, we gathered information from desktop review of existing documents and databases. We used the SRH Global Abortion Policies Database, the MEDAP Medical Abortion Commodities Database, to draw a broad overview of the current situation in the region. In addition, a written country questionnaire was sent to different stakeholders via WHO country offices. So some of the key sources of information were published documents, databases, published and unpublished reports that were collated by WHO, SEAR country offices, Ministry of Health officials, regulatory authority officials, and central medical stores. So this was a collaboration of all these stakeholders to come up with these reports. Next slide. So it is important to note that due to time limitations and the situation that we are in, the COVID situation, and the remote nature of the survey, we were not able to gather primary information from DPRK, India, and Thailand. For these countries, the study relied on the authoritative secondary sources. WHO office country staff, actually in DPRK, had a chance to look at the findings and provided their own feedback on the reports. Next slide. So let me first of all define what are medical abortion medicines. When we talk of medical abortion medicines, we're talking of misoprostol, mifepristone, and misoprostol. These alone, or misoprostol alone, or in combination, are medications that are generally used to induce abortion and to manage incomplete abortion or intrauterine fetal demise. Next slide. So the first point of call, like I highlighted from the pillars, is to have a look if the medicine are actually registered and are authorized to be marketed in the particular country. So we looked at all the countries to see how many products are actually marketed in the particular country. So this graph shows the number of brands that are available, that are marketed, that have been registered in a particular country in Southeast Asia region. So for example, if we look at Bangladesh, we can see that there are 15 different brands of misoprostol that have been registered and that are marketed in the country. And there are 5 different brands of mifepristone that have been registered and that are marketed in the country. And the Combipex, which is the combination of mifepristone and misoprostol, there are 7 different brands that have been registered and that are marketed in the country. So we can also do the same maybe for a country, let's say like Nepal, there are 4 brands of misoprostol, 3 brands of mifepristone, and 6 brands of the Combitech. So it is actually have been noted that the more the number of products are marketed, the easier it is to actually ensure that the product is accessed because it promotes competition and it actually promotes procurement and distribution. Next slide. So once the product has been registered in a particular country, it has to be included in the National Essential Medicine List. So we looked at the latest National Essential Medicine List across all the countries, and we can see that the countries that have most countries have included at least one of the products in their essential medicine list, but very few have included at least 2 medical products in the essential medicine list. We have Bangladesh who have included all the 3, the individual medicines and the Combitech in the essential medicine list. And other countries, they have only included 1. So it is important that the medicines actually are included in the essential medicine list, and this will support actually procurement by the national procurement agencies and ensure budget prioritization when procuring medical abortion medicine. Next slide. So the overview of medical abortion medicine financing and supply chain management, it is based on financing, procurement, and distribution. So what we actually observed was that India and Timor-Leste have specific public health budgets for medical abortion medicines. So from the budget allocation, there is a budget line that specifies that actually specifies medical abortion medicine. In Nepal, public health system activities are often financed from a broader budget, which does not necessarily specify medical abortion medicine. There could be high out-of-pocket financing as clients prefer to use private sector legally or illegally. So in the region, we realize that there could be a high out-of-pocket financing for abortion services that clients actually, when they prefer to use the private sector, whether it's illegal or legal. Then the cost could be higher where the private sector involvement is actually restricted, because when restrictions are enforced in countries, it actually pushes the cost higher. Then in terms of the procurement, we observe that Bangladesh, Bhutan, DPRK, and Timor-Leste have centralized tendering system of misoprostol, though it may be for other uses. So they say centralized procurement of misoprostol that is happening in the 4 countries. In some cases, the misoprostol will be for other uses. Nepal and Thailand, they have decentralized procurement to local level. They have a federalized procurement system where procurement is actually done at local level. Then in terms of distribution, we actually observe that there is a robust commercial distribution system in the private sector, which is available actually in Thailand. Next slide. So the overview of access model used in selected countries. In most countries, registered medical practitioners or specialists such as obstetricians or gynecologists with minimum experience are allowed to provide medical abortion. Some countries allow allied health workers such as skilled birth attendants, community workers, nurses, and accredited midwives to administer medical abortion. Nepal allows the skilled birth attendants, while Thailand allows nurses, and Bhutan actually allows community health workers, ANMs, which are auxiliary nursing midwives and nurses who are trained in managing abortion complications. In countries where legal provisions permit, the private sector and the NGO also support access to medical abortion information and drugs, e.g. in India, Nepal, and Thailand. So availability of medical abortion medicine in private pharmacies is very low across the region, except for a few countries such as India and Nepal. Next slide. So The summary of the successful initiatives and good supply chain practices that are being conducted in the region. I'll go country by country. I'll start off with Bangladesh. So in Bangladesh, menstrual regulation is being used as an alternative to medical abortion because of legal and cultural barriers present. And this is an innovative practice. So menstrual regulation method is provided as a family planning service, and actually it promotes access to abortion services in the country. Then in Bhutan, we can actually see that there is task sharing that is an effective practice to increase access to medical abortion care. Staff at all levels, including community health workers, midwives, nurses, are trained in the management of abortion complications. In GPRK, what we can observe is that there is an ease of access to abortion services and comprehensive policy that is available, the guidelines standard for abortion care, and to allow for extensive coverage and effective service delivery. In India, the central government actually provides specific budget to states, like what we have highlighted before, for procurement of medical abortion medicines. And in India, again, there is an expansion to private sector for the services that help actually to increase the coverage. In Indonesia, there is consistent and creative advocacy effort that has led to the review process for inclusion of misoprostol in the National Essential Medicine list. Next slide. So in Maldives, we can actually observe that inclusion of medical abortion medicines in the National Essential Medicine list is an innovative solution where use is restricted. And in Myanmar, use of misoprostol is allowed in cases where termination of pregnancy is approved by authorized board for the sake of saving the mother, the life of the mother. Then in Nepal, there is a comprehensive and extensive laws, policies, and guidelines that exist that are well documented. Product registration, inclusion in the National Essential Medicine list, public procurement of Comnipex is good practice as it aids rational dispensing and use. Medical abortion services are provided free of cost in the country and are spread to district level, thus removing the barrier to access. In Sri Lanka, what we can observe is that post-abortion care, which includes contraceptive counseling on family planning, who are informed that all methods are available free of cost and of the health institutions providing post-abortion care. Then in Thailand, what we can see is that there is access is widespread and is provided by public facilities, general providers, private providers, and NGOs. Training facilities are available for health workers for service delivery programs. And in Timor-Leste, there is a budget allocation, centralized procurement and distribution of misoprostol, which indicates a good supply chain support for to ensure access to medical abortion medicine. Next slide. So when we look at the challenges and gaps and the good practices that we are seeing in the region, we ask the question now, how can access be improved? So first of all, the access has to be improved by ensuring that the laws and policies and regulation are enabling. So medical abortion can be promoted as a safe, non-invasive and expansive procedure, since the WHO actually recommends medical abortion. Then misoprostol, mifepristone, alone or in combination, should be included in the National Essential Medicine list. And there should be policy that should encourage registration of multiple sources of products of each medical abortion medicine, so that to ensure sustainable access and encourage market competition for better pricing. Medical abortion medicine can be classified as vital in the vital, essential, and necessary system of the essential medicines classification and considered a priority during procurement. So once the laws are there, then the medical abortion medicines should be marketed, should be authorized in the country, and should be included in the National Essential Medicine list. Then,
Terence, you have 1 minute left. Terence,
okay.
1 minute.
Then there should be financing and supply chain. There should be proper financing and of the national requirement that is included into the health budgeting, and for private sector, it should be allowed to encourage expanded distribution. Then the access model that can be used, some include the task sharing, like what we have learned today. Then there's a potential use of telemedicine, especially in the times of COVID. Then medicine provision access through non-physician providers such as nurses, midwives, and the private sector to access through certified pharmacists can be considered. So once all these areas are actually identified, they can be actually be used to support access to essential medicines and medical abortion medicines in the country. Next slide. So thank you very much for giving me the opportunity to present on the regional update on the access to essential medicine in the region. Over.
Thank you, Terence. So, Terence gave us a brief overview of the whole region, and the important part is it's not only the accessibility of the medicine, it's also about the availability of the quality medicine, and then some mechanism in the health system to ensure that there is a standard procure mechanism and there is a well-established supply mechanism. Otherwise, even in a country where MA services are available up to the grassroots level, if we don't have a medicine, quality medicine on the service site, then this is not going to work. So it's very important for us to see, to look at the procurement and supply chain management mechanism in the country. So thank you, Terence. So I request participants, if you have any questions, please put the questions in your chat box. Now I request Dr. Hin Hin Win. She is the Deputy Director of Maternal and Reproductive Health Division, Department of Public Health, Ministry of Health and Sports. And she will be highlighting on the post-abortion care services in Myanmar, provision and services in Myanmar. So thanks, Dr. Hin Hin, for being here, and I request you to start your presentation. Thank you.
Thank you, Dr. Mira, and SEAR office person and all attendees. Good afternoon, all. So kindly let me make my presentation. Next. So I'm going to discuss with the three components. And the first is our current situation, and then law and policy related with abortion, and thirdly, post-abortion care services and way forward. Next. Okay. So related with current situation, let me start with the country profile. Next. Next. Okay. Next. And so our country population consists of 51 million according to the census, and young people consist of 28%. And we have 7 states and regions, and we have the geographically hilly, central plain, coastal, and delta region. And we have 135 ethnic groups. So there are many varieties and diversity. We have the healthcare provision system with the mixed public and private sector. And public sector mainly responsible for Ministry of Health and Sports, and private sector also composed of the private hospital, GP clinics, and ethnic health organization clinics, and INGO clinics, etc. Next. Next, please. Total fertility rate is around about 2.3, whereas the adolescent birth rate is increasing trend, and now 36 per 1,000 girls of age 15 to 19. And we have the contraception prevalence rate of 52% and unmet need of 16%. which is a little bit high unmet need, and it also contributes and save abortion. According to the hospital data, the abortion rate among all pregnancy is 12%, and which is the one of the 10 leading causes of all hospital admission during 2016. Next, please. If we review the maternal death surveillance and response report, as you all see, the abortion rate is the third leading cause, both in 2017 and 2018 report. Next. Next, please. Regarding research and study, we had also conducted pathways to post-abortion care, and in which among abortion cases, 83% are married, and they also have the previous miscarriage experience or attempts to end a pregnancy. And in one community dialogues done by Adolescent Sexual Reproductive Health Project, it was found that youths are unwilling to seek services from the healthcare providers as they concern for their privacy and confidentiality. Next, please. Next, regarding law and policy related with abortion. Next. Next. We have Myanmar Penal Code, in which the Article 312 to 316, it mentioned that miscarriage is illegal and highly restricted except performed in good faith for the purpose of saving the life of the woman. And according to the terminology, the termination of pregnancy is used rather than abortion in the clinical sites, and it can be provided for the sake of saving women's life with the approval from clinical management committee of respective hospital. And in that committee, the committee is headed by medical superintendent with involvement of the obstetrician and gynecologist, and it is decided case by case. In 2019, MOHS can approve new sterilization criteria in which some restrictions are eased to get more accessible and more available to get sterilization for the women. Next. Next, please. Another law is the Prevention of Violence Against Women law has been drafted by the Ministry of Social Welfare, Relief and Resettlement in collaboration with all stakeholders, including civil society organizations and women groups. So this is the law which is aimed to prevent the violence and other types of harming to women. And in that law, the clause include that as the survivor has the right to receive reproductive health services, including contraception or to have a child in accordance with her own decision. And another clause is the survivor who is under one of the following conditions can conduct abortion with her own decision and if permitted by the medical board. So one criteria is if the pregnancy continues, her life or mental health, physical health can be endangered. And another criteria is if pregnancy is due to rape. So this law has been under lengthy review process by two government time, 2011 to 2015, and currently 2016 to 2020 parliaments. As it will be now, it is going near to be passed in coming years. Next. So regarding policy issue, in 2017, the policy brief for abortion were developed with the technical support of Bloomberg and our ministry. In the policy brief, levels of abortion prevention are matched against the services offered in the healthcare levels. And another policy is we are also we are finalizing and now waiting for the approval for the policy of sexual reproductive health and rights, SRHR policy, which has already approved from the ministry, and now we are waiting approval from the cabinet. In that policy, the abortion services must be accessible and available to the women and who needs the services. Next. So this part is how we are providing the post-abortion care services. Next, please. So according to our legal situation, we don't have the specialized training or training manuals for termination of pregnancy. However, we have the guideline training manuals, standard operating procedure SOP for post-abortion care. And we are going to strengthen those post-abortion care trainings and services throughout the whole country. And post-abortion family planning, counseling are also included in the post-abortion care services. Next, please. For post-abortion care, the safer method like manual vacuum aspiration for post-abortion care has been piloted since 2000 in one of the hospital in Yangon, and since 2014, Maternal Reproductive Health Division and the Ministry of Health have scaled up post-abortion care in Myanmar. Now nearly covered 80% of the states and regions, and we are working together with them, with the partners such as IPAS, MSI, PSI, and Myanmar Medical Association. Next, please. Next, please. Okay. So this table shows the current implementation service and 4 levels of prevention in levels of healthcare provision. So regarding the family planning services, we can provide all 3 levels: primary, secondary, and tertiary level. Whereas safe methods of abortion, we cannot provide in all 3 levels, except only some cases with the defined criteria in the tertiary hospital, whereas we use the term as the termination of pregnancy. And for the post-abortion care services, we can provide starting from secondary level, so secondary level and tertiary level. And as post-abortion family planning, we can provide it in all 3 levels. Next, please. This slide shows about the drugs we use for the management of post-abortion care. WHO guideline mentioned that misoprostol only or combination of mifepristol and misoprostol can be used for intrauterine fetal demise or induced abortion. However, in our country, only misoprostol is registered under FDA and available in the market. And it is also included in our national list of essential medicine as oxytocin drug. For our public health sector, we used to procure and distribute misoprostol, but it is for the mainly for the prevention of postpartum hemorrhage, but for the medical management of post-abortion care, only some we can distribute to some public health hospitals only. Next, please. This is the way forward to improve post-abortion care and to reduce abortion-related burden in Myanmar. So the first one is we need to strengthen family planning services with focus to the vulnerable groups such as adolescents, youth, and migrants, etc. And the second one is we are going to provide quality post-abortion care services using surgical method or medical method. And our effort is to conduct task shifting to midwives for medical management of first trimester post-abortion care using misoprostol. So it is going to be conducted in some pilot townships, 8 townships, and 4 states and regions with the collaboration of IPAS organization. And another way forward is we are going to provide post-abortion care services up to second trimester. So that second trimester post-abortion care guideline has been developed and it is in the process of approval. And the last one is we have discussed and approved for the termination of pregnancy criteria, which have included relaxed points of criteria. And that's all my presentation, and thank you so much.
Yeah, thanks. Thank you. Thanks, Dr. Hinin. It was a very good overall overview of the post-abortion services in a country. And obviously in Myanmar, we will use the term termination of pregnancy. So we are so happy that you're thinking of having some relaxation on the indication of termination of pregnancy. So thank you for all the panelists and thank you so much for all the participants here. So there are a few questions from the participants. So I would like to put question to Antonella first because she would want to join another webinar in 10 minutes time. So Antonella, there is one it's not exactly a question, just one was sharing an experience that he or she shared her experience in 2013 when she or he was working as a casualty medical officer in a remote village where they received a woman who was profusely bleeding due to some kind of the procedures for termination of pregnancy, which was tried by ASA. ASA is a volunteer health worker in India. So that time, our participant, he or she thought that the main culprit is ASA. But now in 2020, now he or she realized that it's not ASA, it is actually equally the untrained service providers are equally a culprit or equally cause for unacceptable death in case of complication of abortion. So can you highlight some of the key factors which would help to let this kind of patient leave, like to manage this kind of abortion complication cases. So starting from policy to the service side, if you can just briefly highlight some. Thank you. Thank you for the question. Thank you.
Great, thank you so much. So I think this example really illustrates the fact that there are several variables contributing to the problem of unsafe abortion. So when we think about the delivery of safe abortion care, which includes both safe abortion and post-abortion care services, we need to think about the various components. So some have been already highlighted, things like commodity issues, financing, service availability, but there are also things like training and equipping, monitoring, making sure that patient-centered care is being delivered, as well as an appreciation of the barriers that exist. And one other, I think, important factor is that we also need to find ways to appreciate the cultural and social norms that are contributing to these issues, as well as stigma, because individuals really need to be capacitated, feel safe, feel empowered to be able to present for care where services are available legally, and for post-abortion care as well, without the fear of being judged, concerns around privacy and confidentiality. So it's a multifactorial issue, and we still have lots of work to do. And just addressing the legal and policy environment won't be enough. We really have to tackle the components of the system, as well as appreciate those that are participating in self-management and how we can facilitate that where that's appropriate. Over.
Yes, thanks. Thank you, Antonella. And there is one question for Sophia. In this new study, there is a huge gap in SRH care. So, and what will be the effort during this pandemic period to cover that gap? What would be the extra efforts that we will be doing during this pandemic period? Because we never know, this is going to be more extended, protracted. So what do you think? What may be the possible ways that we can do that? Yeah, thank you.
Yeah, thank you, Dr. Mira, and thank you so much for that question. So I would say first that we've seen that COVID-19 is already having adverse effects on health systems and really on individuals' ability to access services. One thing that I noted in my presentation is that one of the primary drivers of the declines in unintended pregnancies globally has been through improved access to and use of contraception. The pandemic could really threaten to reverse those declines due to challenges that many of the other panelists have noted around supply chain issues, diversion of providers to the response, lack of access to health facilities. I would also say that the pandemic is really illuminating existing gaps and strains in healthcare systems, which have shifted critical resources to responding to the pandemic, and away from basic sexual and reproductive health care, including abortion services. Additionally, some countries have deemed abortion not an essential service, thereby making it unavailable even if it is legal. So that gets back to some of the gaps between law and implementation. I would just close by saying it's well documented that the denial or lack of access to sexual and reproductive health services, including safe abortion, is especially harmful for marginalized populations who are already dealing with many of the barriers that other panelists have noted, from legal, economic, social, cultural, logistical barriers to care. So I think we really need to pay special consideration to people and communities who are already facing structural and systemic barriers before the pandemic, because these are the inequities that are really exacerbated under the weight of a global crisis. I just close by saying that our research teams at Guttmacher have done pretty extensive analysis already to date of the impact of COVID-19 on various aspects of sexual and reproductive health care, and have begun to set forth policy recommendations that align with many that we've heard today. So I would just recommend checking out our COVID-19 resources page. You can search for Guttmacher COVID-19 to learn more. So thank you so much for that question, and back to you.
Thanks, Sophia. So there's one question for Dr. Hindin. Dr. Hindin, there is a question that what is the government's perspective on medical abortion in Myanmar?
Yes, sorry, I couldn't hear well.
That is
Can you
the
repeat?
participant. is, yeah, they're asking like, what is the government's perspective on conducting a termination of pregnancy by medical method in Myanmar?
Okay, thank you for the question. Regarding the perspective of the government, it is hard to say that like agree or disagree, because we are like Buddhist country, and most of the citizens are Buddhist, and also there are some strong religious organizations. Although we have active women groups and women organizations who wants to stand for the women uh, women safety and women empowerment. Uh, so I cannot estimate the government perspective, but I have to say it is very difficult situation for especially for our country. I have to say that we have, on one side we have the religion, and on other side we have the care and services for the woman. So I cannot say definitely. Thank you for the question.
Thank you, Dr. Indian. Thank you for making your time here. So with this, we have crossed our time. So I would like to hand over this floor to Dr. Nina Rena for closing. There was one question for Terence, so we would answer back to you all later by email. So thank you, the participants, and thank you, Dr. Nina Rena. Thank you all panelists. Thank you.
Thank you very much to the panelists. I think it was a very interesting webinar. I see there are 3 or 4 take-home messages. One message is that we need to strengthen our recording and reporting systems so that we get enough information on the situation and the magnitude of abortion and unsafe abortions and the deaths and the complications related to it. We need to, most of the countries and state governments and ministries of health are trying their best, given the socio-cultural milieu, religious milieu. They are trying to do their best to provide access to services to women. Some have to save the life of women, some have restrictions to save the, to really also look into the mental health issues of the women. So there are, I think, ministries of health are making very good efforts to make sure that women have access to, those who need have access to safe abortion services. So, the second, so we need more data, we need more information. Data leads to advocacy and initiation of a policy dialogue with the government. So I think we need that. The second message is very clear. I think we are very fortunate that there is medical abortion is safe, is available up to certain weeks, of course, and can be, can be, given to women. And this is something which is, I would say, the life of women have changed in countries where medical abortion drugs are available, and they can really take it under, of course, with consultation with their provider. But then Dr. Terence highlighted very well what are the issues related to availability, accessibility, acceptability, and affordability. And affordability, especially when we talk of out-of-pocket expenditure, and also when we talk of quality of the drugs which are available. So I think countries where this is relatively as a choice is available, I think we should really look into these issues related to affordability of good quality, medical abortion drugs, and giving them access to the women. And lastly, I would say that these COVID times are difficult times for all of us. COVID is not going to leave us very soon. We have done some mapping of disruption in services for SRM and CH area of work, which also includes access to contraception and access to, of course, abortion services, along with UNICEF, UNFPA, WHO, and we found that especially during the lockdown periods, there was disruption in services. And then there were 3 webinars held where ministries of health made presentations on how did they address this disruption in services and how did they mitigate the indirect impact of COVID on the lives of women or children and adolescents. So those were very interesting presentations, and those are available with us. And we are trying to document it in a systematic way. How can we reduce the disruption? But at the same time, I think it is the violence against women, the domestic violence has gone up. Marital rapes are a problem. Access to contraception especially during the lockdown period, is a major issue. And if you get pregnant, then access to safe abortion services is also a major issue. And there the barriers are both sides, provision side as well as demand side. And demand side barriers are people are really scared of going to the hospitals, for any kind of service. They are trying to see if they can delay seeking care. So those are some of the. I remember, somebody was narrating me a story yesterday that sort of there was somebody who, because in India it is at times, and in many other countries it's over the counter drug. The availability is so much that they went to the pharmacy, got it. The woman took it, and then within 2 days she was in terrible pain, and it was an ectopic pregnancy, and she had to be shifted to hospital, and only then her life could be saved. So I think availability, accessibility, affordability, acceptability, when all the four are there, it has to be backed up with a good teleconsultations and access to a good advice, so that those who are taking it, we make sure that there are no ectopic pregnancies and there are no other complications which can happen as a result for countries where these drugs are made available and accessible to women for medical abortion. So with these words, I would like to once again thank everyone, especially our wonderful panelists, Dr. Antonella, Ms. Sophia, Mr. Terence, and Dr. Ninin Luen, who has shared Myanmar experience on the situation and the response of the government, which is, I think, quite commendable. I'll also like to thank my colleague Dr. Meera for moderating this session. She is very, very passionate about making sure that no woman should die because of unsafe abortion. And being a obstetrician and gynecologist herself, I think she may have handled many, many complications. And Nepal had a long journey to document how many women were dying and how many women were landing up in the hospitals because of complications of abortions. And that was such a big burden on the health system. And then I remember that it was, legalized with certain, of course, restrictions, which happens in every country. And she was a major, driver behind these things. So I'll also like to thank Professor Dilip Mavlankar, our collaborator, for these webinars, and I'll also like to thank all the participants who are still hanging on. I see a lot of them are still there and they are from Ministries of Health. I see a lot of people connected. I'd like to convey our thanks, and please don't forget to join next week again, Wednesday, same time, and we have a very nice webinar on aging. So see you then. Bye-bye. Thank you.
Thanks. Yeah. Thank you, ma'am. Thanks.